Our fourth presentation is a pre-recorded presentation entitled An Artificial Intelligence Approach to Identify Pneumatosis in Infants with Suspected Necrotizing Enterocolitis. It will be presented by Dr. Weller from Johns Hopkins.
Thank you for the opportunity to present this research. I'm excited to talk to you about our work predicting necrotizing enterocolitis, or NEC, and I have nothing to disclose for this talk. So as background, NEC is a rapidly progressing disease of neonatal bowel that results in significant morbidity and mortality, especially for preterm infants. Classically, NEC is diagnosed by radiographic signs of bowel wall injury, such as pneumatosis and portal venous gas, as you see here, and pneumoperitoneum. But many babies with NEC never develop these findings, and providers often have uncertainty whether these signs are present on images. So we hypothesized that artificial intelligence, specifically a deep learning algorithm, could help us recognize pneumatosis on neonatal abdominal radiographs. And because there's uncertainty around diagnosing early signs of pneumatosis, we set out to first prove that an image classifier could detect the unarguable cases of NEC. To accomplish this, we gathered published images from online repositories such as PubMed and Radiopedia, making sure all images came with clear labels of disease pathology. This gave us 214 images with pneumatosis and 292 controls with other gastrointestinal pathology. After cleaning and dividing our data, we then developed an image classifier to detect NEC-induced pneumatosis. This used machine learning, specifically a type of deep convolutional neural networks called a ResNet-50, which can recognize subtle patterns in images. We took a model which was already able to recognize everyday objects, and in a process called transfer learning, we tweaked it to specifically recognize pneumatosis. This helped us train a model on a relatively small number of images. We then applied it to the test set of images it had never seen before to assess model performance. So how'd it do? On the holdout test set of 49 images, our model achieved an accuracy of 88%, missing one control and 5 cases of NEC, with a moderate sensitivity and high specificity for recognizing pneumatosis. Receiver operating curves help us understand how well the model distinguishes between cases and controls at different thresholds of detection. Our model achieved an excellent area under this curve of 0.91. Alternatively, the F1 score is a way to look at model precision, also known as positive predictive value, and recall sensitivity. Our model achieved a good F1 score of 0.84. A common problem with neural networks is that it's really hard to figure out exactly how the model makes its predictions. It's called the black box problem, and one way around it is to use GradCam heat maps, which highlight areas of the image that most informed model predictions. This helps us confirm the model is basing its diagnosis on bowel and not unrelated findings like an umbilical line or curvature of the spine. Reassuringly, we found the image features that most generated predictions for our model were areas of pneumatosis and bowel wall edema. So can we use this model in clinical practice? Not yet. This was a pilot study, and we need to next update the model with more images so that it can recognize pneumatosis in more real-world settings. In parallel, we're also comparing this model to the performance of providers to see if it would have clinical utility. So far, we've surveyed surgical residents, asking them to rank their confidence in diagnosing test set images. And we're seeing the model performs as well as surgical residents, and that surgical residents lack confidence in detecting NEC. This is an example of an image that the model correctly detected as having pneumatosis, but residents were less confident. This suggests that an image classifier may be helpful in clinical practice. So in summary, our preliminary work shows it's possible for a neural network to classify hallmark cases of pneumatosis on neonatal abdominal radiographs. While our model needs updating in a larger data set, our work is a promising first step towards helping providers confidently recognize features of NEC on imaging. This could help facilitate earlier treatment and minimize potential bowel wall injury. In conclusion, I'd like to thank the Pediatric Surgery Department and the Malone Center for Engineering at Hopkins for the opportunity to work on and present this research. Thanks.